Welcome to Ivy Concepts, your first NUR108 lecture that is being given via YouTube because we are having a snowstorm today, and you will need this information for your Ivy lab, which is Thursday morning. I ask that you please review the class study guide, Introduction to Ivy Therapy, and try to do as much of the reading as you can ahead of time, and also definitely review the readings in your nursing skills book, Clinical Skills in Nursing, your Brennan book, for the Ivy Lab on Thursday. And hopefully we will all see you then. Okay, starting off with Ivy Concepts, the history of Ivy therapy. For centuries, actually, and then through the Dark Ages, you had people thinking that the veins and arteries and heart and everything were pumping air around through the body. They also thought that the liver was the main blood-forming organ, all kinds of different things. So in the 1600s, William Harvey is actually credited as the first bringing forth the study of the human circulatory system. He also pulled on other ancient observers from the Egyptians, Greeks, and Roman civilizations that came before him. However, they really, as I said, thought that the heart and the vessels during life contained only air. Harvey did an interesting thing in front of the Royal College of Surgeons. He demonstrated using a snake. He had a live snake, and he occluded the vein of the living snake, leading. Actually, I'm going to advance the slide to Harvey. Sorry, I'll try to keep remembering to advance the slide. He occluded the vein of a living snake, leading into the heart, and the heart paled and it actually stopped pumping. When he opened it again, it resumed a purplish reddish color, and then the arteries actually bloated and the heart bulged. When he blocked the arteries, the heart bulged and it swelled. And he was able to demonstrate, he proved that the circulation goes in a circle. Much of his information has not survived because there was a very huge fire in London, and that burned the library of the Royal College of Physicians, and all his papers, books that were kept there, all was lost. So all that was saved was some notes from his lectures that was given in the lecture that was given in 1616 to the physicians of the Royal College. His personal belongings were all destroyed by Cromwell also in 1642. They weren't real happy about his ideas. He was born in 1578. He was educated in England and Cambridge, and in Italy he went to med school. He attended, as a physician, he attended James I and Charles I in England. It's just this history stuff, but anyway. In the 1800s, you had the first human blood was transfused by an MD. In the 1900s, you had, they determined the differences in blood. All I can think of is how many people they killed off with incompatible blood transfusions before then. 1935, the continuous slow drip method was first started. You got to remember, this is just before World War II. And then in 1940, which was the beginning of World War II, you had the first IV therapy nurse at Mass General Hospital. And in 1945, you had the first flexible plastic IV catheter. 1973, the Intravenous Nursing Society was established, and in 1975, they started publishing their Journal of Intravenous Nursing. Perils of IV therapy. Up to 90% of clients may require some form of IV therapy. Medication errors account for 2 in every 1,000 hospital deaths and are a frequent cause of malpractice suits. You have to know and conform to your facility's standards of practice. It's really important. And refuse to participate or to perform a practice if it is not in the scope of nursing practice. And a way to find out your scope of nursing practice related to IV therapy is if you click on this particular link, it will actually take you to the Health and Human Services, to nursing, and you click on nursing practice, and from nursing practice you look at the advisory rules of nursing practice. And this will bring you into the CMR 4.00 Task Force report. And then you click on IV therapy, and it will give you all the different things, all your different authorities and the scope of practice, purpose, advisory, all in IV therapy for nurses and actually LPNs as well. And here are your Massachusetts general laws and your 244 CMR code, registration of board of registration of nursing. Okay, so you've got some legal do's of IV therapy. Do document only what you observe, what the client said, and what was done. No opinions. Do write no IV-related complications observed. Otherwise, you're going to have to include all the individual possibilities that could possibly occur, and you don't want to have to do that. Do give details about complications. Do document the catheter length when you're removing it. Legal don'ts of IV therapy. Don't write good blood return to verify patency. That doesn't always work, especially in pediatrics. You don't always have a blood return, so you really can't state that. Don't document patient tolerated the procedure well. Don't write catheter tip intact when you remove a peripheral venous access device. You cannot be sure of that. The best thing you can do is to take and compare a brand new catheter tip with the old catheter tip you just removed and make sure that they're the same kind and make sure that their dimensions are the same, the length is the same, and everything looks the same. Don't rely solely on charting by exception or check off flow sheets to do your documentation. Now I've just stuck in some slides about administering medications and your responsibilities and the things that you have to be knowledgeable about and your laws that govern you. Your pharmacology calculations, you only administer meds you personally prepared, don't leave medications at the bedside, all the things that, we've talked to you about and we taught you last semester when you were giving meds in 107. So if you can read through that on your own. You've got your 6 rights or 10 rights, is it up to now, of medication administration, but I'm just reminding you to keep those in mind because they're going to definitely apply here as well. Now, let's get on to the parenteral medications. It's common nursing practice. They're absorbed much more quickly than oral medication. You give an oral medication and it's a problem, it wasn't the right med, you suddenly realize you just gave the wrong med to a wrong patient. Hopefully that never happens. And it should never happen. However, if it ever did happen, you have time. You have time that oral medication is not going to be absorbed right away as long as you quickly you could give antidotes, you could be monitoring the patient, be aware of it, everything. Even if you give something SC or IM, you've got some time if anything was incorrectly given to a patient and say you're the charge nurse covering the nurse that did that. However, when you give something IV, you have given that solution of medication. It cannot be taken back, and it is in there immediately at, peak. So it's instantaneous. We talk about when you give medications and you're given the responsibility to give medications, it's actually a very scary way to kill somebody if you do it incorrectly. And actually, if you do IV therapy incorrectly, it's a way to kill somebody very quickly. So I do mean to scare you actually, because I want you to be very, very careful. And your integrity with giving medications and sterile technique and everything with this has to be unquestionable. Aseptic technique, preventing infection, absolutely. You have to, your technique and your care that you take of your patients has to be your medical ethics, your nursing ethics, your integrity is absolutely unquestionable. Okay, actions of drugs in the body. We often use the term half-life, and that's the time interval. It's a term that we use to describe the time interval required for the body's elimination processes to reduce the concentration of a particular drug in the body by 1/2. That is your definition of half-life. Oral drugs are absorbed and reach peak slowly and I'll show you a slide about this in a couple minutes, slowly until elimination rate catches up to absorption rate, and then the drug level decreases. IV drugs, they're going to hit their highest level immediately after administration, and then they decrease over time. Additional doses are given at regular intervals to maintain that therapeutic level. If you look, one thing I do want to mention about this, I'm showing you a bag of IV fluid because I want you to see that you always write on the label and then you adhere the label to the bag. You do not write on the bag because it is semi-permeable and it can go through into the medication. So you always write on the label and place it in the bag, and always place the bag, hold the bag how it's going to be when it's hung, because you don't want your label to be upside down on the bag. So just take care to do that. I'm also going to remind you about this later because it is important never to write on the bag. But here's that slide I told you was coming to show you the concentration of blood plasma following a single dose. And here you're seeing your oral dose there. It goes up slowly and it reaches that peak plasma level and then it starts to decrease. And then you've got your intravenous, as you see, when you give it, bang, it's peak, and then it slowly decreases over time. Next slide. There's a number of drugs that we monitor regularly to establish the therapeutic level, and it's to check that the blood serum level of a particular drug in the patient's body or in blood at a set time before and after the administration of the drug. So you're going to do a peak level would be the peak time of the drug, and then the trough would be just prior to the drug being given again. And you want to determine if the level of that drug in the patient's body is actually therapeutic. You want to check that it's, is it subtherapeutic, and that's not really good because they're not going to get any advantage of it. And if it's toxic, that's really bad. So if you have a toxic, you've got renal or liver failure and decreased metabolism and increased drug circulating in the. If you've got liver failure or renal failure, excuse me, I'm going to rephrase that. You're going to have an inability or decreased ability to metabolize that drug, and so you're going to have an increase in the drugs circulating in the body. Now, common drugs that are commonly monitored are vancomycin, absolutely, digoxin, theophylline, aminoglycosides. Like gentamicin and anti-seizure medications. Absolutely, those meds are going to be monitored. You want to look at the peak level, which is the highest concentration of the drug in the bloodstream, and you want to look at trough, which is the lowest concentration of the drug in the bloodstream. The objective is for the peak and the trough to fall within that therapeutic range. Parenteral fluid therapy. IV solutions contain dextrose and electrolytes mixed in various proportions with water. They utilize with no other route of administration is available. The patient is that sick that they're vomiting, they aren't able to absorb it, they're having diarrhea, so it's going right through them, and they're losing their electrolytes by vomiting and having diarrhea, or they're just they're bleeding through the GI system, and you can't give them any fluids or any nutrition that way. You can't give them any fluids that way. So it's utilized when no other route of administration is available. It's now quite common actually to give parenteral IV parenteral fluid therapy. It's given in hospitals, outpatient diagnostic and surgical centers, and clinics and homes. What are the purposes? They're to provide water, electrolytes, and nutrients to meet daily requirements. You're going to replace water or correct electrolyte deficiencies, and you'd administer medications or blood products as needed. As you learned in 107 in fluid and electrolytes class, if your patient is fluid deficient, they've got a loss of extracellular fluid exceeds the intake ratio of water and electrolytes that are lost in the same proportion as they exist in normal body fluids. And this can happen through dehydration, because of loss of water alone, now you've got increased serum sodium level. May occur in combination with other imbalances. Other causes of this would be fluid loss from vomiting, diarrhea, GI suctioning, things that I discussed already, sweating, decreased intake, and inability to gain access to fluid. Risk factors might be diabetes insipidus, adrenal insufficiency, osmotic, diuresis, hemorrhage, coma, and third space shifts. Fluid and electrolytes were discussed in 107, as I said. And it'll be more thoroughly addressed later on in 108 when you have your continuation of fluid and electrolytes and acid-base balance. We're really discussing IV concepts today, but it's hard not to have some mention of why you need IV fluids without at least mentioning fluid and electrolyte balance. Okay, so manifestations, the patient is sick and needing to have fluids replaced because they have fluid volume deficit would be rapid weight loss, decreased skin turgor. Oh, I've got to move the slide, apologize. Rapid weight loss, decreased skin turgor, oliguria, concentrated urine, postural hypotension, rapid and weak pulses, increased temperature, etc., etc. Laboratory data, you're going to be checking your lab data. It's key because you really need that blood work on a patient to make decisions about which IV fluid to initiate and whether you even need one or not. So you want to check your BUN, check your serum creatinine, check your crit, and any serum electrolyte changes. Medical management, you want to provide fluids to meet body needs. Oral fluids, and in Lewis there's actually a very nice table of 1719 on page 326 in Lewis of IV solutions. All right. Now you need to think a little bit about your nursing diagnosis and your assessing. We've kind of talked a little bit about assessing and what's wrong, and now your nursing diagnosis is defining what's wrong, and then we're going to look at interventions and management in a little bit. So here's a list of some of your nursing diagnoses related to IV therapy. Your desired outcomes, you want to get them back on track. You want to maintain or restore normal fluid balance, maintain or restore normal balance of electrolytes, get that pulmonary ventilation and oxygenation under control, and prevent associated risks such as tissue breakdown, decreased cardiac output, confusion, and other neurological signs that are going to happen. And after you've had your blood work, it'll determine the type of fluid volume again and electrolytes. Electrolyte deficiencies that you have to replace, and the orders will be obtained. Nursing interventions would be you'd be monitoring your patient, fluid intake and output. You monitor that IV at least hourly, absolutely at least hourly. Cardiovascular and respiratory status are going to have to be monitored, and results of lab tests. Orders will be written to continue regular assessment of lab tests, and you've got to obtain or request those orders as needed if you think the patient's having some changes and you want to check more frequently. You want to assess the patient's weight, location and extent of edema if present, skin turgor, and skin status. Check the specific gravity of urine, and you want to watch that level of consciousness and the mental status. You want to assess your patient and the effectiveness of the IV therapy. And you've got that risk. If you see increased edema and increased weight, then you're looking at fluid overload, and you want to be very careful of that. Very vigilant. You also need to do fluid intake modifications, dietary changes, parenteral fluid and electrolyte and blood replacement. Here are also other measures that you need to consider. Would be administering prescribed medications and oxygen, providing skin care and oral hygiene, positioning the patient appropriately, and scheduling rest periods. Now, this is a new slide. This has the things you're going to be looking at through the semester and seeing with your patients. So I really do want you to read through these. Some of them you've already got your list of what you have to study for the IV lab, but then you might want to take a look at some of these as well. As you are going to be taking care of patients and performing these procedures, and you are going to need to know how to perform them. Starting an IV infusion, you're not going to be starting that until second year, but you've got to read through it as you'll get an opportunity to observe IVs being put in, and it'd be nice if you know what's going on, and that way you understand it better so that you'll be able to then transfer that knowledge when it's your turn to try. So you want to starting an infusion, using an infusion pump or controller, maintaining IV infusions, maintaining intermittent infusion devices, discontinuing IV. We'll actually be practicing that in lab this week. And you probably have the opportunity of seeing patients receive blood transfusions or blood products. Another thing I didn't add here would be actually 18.8, managing central lines. It would be a good idea to read through that as well, please, because you will be taking care of patients. A lot of times your patients will have central lines in, or at least they might have PICC lines in, and you want to follow those careful procedures. And as I said, most of these skills will be reviewed in the Ivy Lab on Thursday. Hopefully we have it. This is just to look at the different veins. When you put in an IV, you should start lower in the hand, so closer to the hand rather than up, because you have to keep moving up the arm if a vein is blown or the IV is blown, and you have to restart the IV. So you want to make sure you start low. You want to check if your patient's right or left-handed and avoid that right or left hand that they use more often. It's great when they come up from the ER and they've got that antecubital IV in their right hand and they're on their cell phone with it up in their ear, and your Symbic pump is going to be alarming constantly, telling you that it is an occlusion because the patient's bending their arm. And if they just put it in the other arm, it probably would be a lot easier. So you have to keep reminding your patient to please use their phone on the other side. You avoid a line that has an AV fistula in it. You avoid a limb if the patient had a mastectomy on that side due to impaired lymphatic flow. And as I said, the IV access sites move progressively upward on the limb. In adults, we typically do not ever use the leg veins. You'll see them frequently used in children. So don't be thrown by that, but they don't in adults because, and you might say, well, gee, we use them in kids, why don't we use them in adults? There's a really high risk of thromboembolism, and you do not want to do that. I actually have a good article about it if anybody's interested in it, but the article's getting a little old. But it is quite a good case study of what could happen. Okay, and there's just some more examples of your veins. This is a subclavian vein insertion. And this is your left jugular vein insertion. Now we're going to move on to types of IV solutions. So you've got your isotonic, your hypotonic, and your hypertonic solutions. Your isotonic is pretty much the same osmolarity as serum. Its total electrolyte content is about 310 milliequivalents. So that basically expands your okay, let's see. Your ECF. Your hypotonic solution is less osmolarity than your serum. That has a total electrolyte content of less than 250. And that one's going to be a way to give free water. Your hypertonic solution, that's got a higher osmolarity than your serum, and it's got a total electrolyte content of greater than 375 milliequivalents. So, and we're going to talk more about these later, actually, in later slides, but I'm going to talk about each one of them, in fact, specifically. The osmolality and electrolyte content of IV solutions is compared to plasma, and that's what I just did, and I talked about the different types of solutions. It's written on the IV bag. You can actually look at it. It's right there on the IV bag. And there are great charts in Lewis. And again, look at table 1719. I'm going to remind you to do that. Okay. And the osmolarity of plasma is actually about 300. So that's the comparison. Okay. I told you I was going to remind you again, remember that the IV bags are semi-permeable and you cannot write on them. Write on the label and affix the label the appropriate direction so that when the bag is hanging, the person can read the IV medication that's in it or some additive that has been put into it. Okay, so to start with just the isotonic solutions, which are the same osmolarity as serum, they're close to that of the ECF. They stay inside the intravascular compartment, thus expanding it. Their indications would be for someone who has hypotension or hypovolemia. Your risk is that you could fluid overload somebody. So examples of these type of isotonic fluids would be lactated ringers, normal saline, which is 0.9% saline in water. Normal saline has a total osmolality of 308. Be careful not to fluid overload a patient with hypertension or heart failure, as these fluids expand that intravascular space. Okay. This does not cause RBCs to shrink or to swell. And just so you know, 1 liter of isotonic IV fluid expands the ECF by 1 liter. It expands plasma only by 0.25 liters because as a crystalloid fluid, it diffuses quickly into the ECF compartment. 3 liters of isotonic fluid is needed to replace the loss of 1 liter of blood, just so you know that. Now, hypotonic solutions, excuse me, I apologize. Hypotonic solutions would be, they'd be hypotonic compared to plasma. So they dilutes the serum. Water is pulled from the vascular compartment into interstitial fluid. So an extracellular fluid that fills the spaces, interstitial fluid is, the definition of the interstitial fluid is an extracellular fluid that fills the spaces between most of the cells of the body and provides a substantial portion of the liquid environment of the body. So this again, all of this will be reviewed again further in fluid and electrolyte class. I just want you to have a basic understanding that IV fluids are different, why they're different, and why you might use a certain type. So indications of a hypotonic one would be dehydration or hyperglycemia. Risks: sudden fluid shifts, decrease in blood pressure, cardiovascular collapse, increased intracranial pressure would be the indications of risks of using this type of fluid. Examples of a hypotonic fluid would be 0.5% or quarter normal saline, or half normal saline. Excuse me, that's half normal saline and dextrose in it. Okay, so we'll move on to hypertonic fluids. These ones have a total osmolality exceeds that of the ECF, pulls fluid and electrolytes from the intracellular and interstitial compartments into the intravascular compartment. It's a more concentrated solution. You have to be very, very careful. Indications for this would be to stabilize someone's blood pressure, increase urine output, and reduce edema. As I said, they're going to suck the fluid out of that interstitial compartments and put it back into the circulation. The risk would be it's dangerous in setting of cell dehydration. Sorry, my dogs are barking in the background. Examples: D5 half normal saline, D5 lactated ringers, D5 normal saline, and 3% sodium chloride or albumin. It's administered very cautiously, especially and slowly, because it can cause extravascular overload and pulmonary edema. Let's see. Okay. Other intravenous substances, you might have the experience of seeing blood transfusions, and that skill is also in your clinical nursing skills book in chapter 18. I've referred you to it. And nutritional support such as total parenteral nutrition, or TPN, and that's chapter 19 also in your skills in clinical nursing book. So you can take a look at that as well. Okay, essential nutrient sources. Nutrients and sources. Okay, do you provide essential nutrients from IV fluids? Let's take a look at that. Water, yes you do. Carbohydrates, some, because you might have some sugar in it. Protein, no, it's not there. Fats, no, it's not there. Micronutrients, minimal, if any, or and if added. Um, Vitamins and minerals, if they're added to the bag, usually the IV fluid is like a yellow color if you've added vitamins to the bag, but normally you don't have those in your regular IV fluids. So it's basically imbalanced nutrition, and it's really less than body requirements would be your nursing diagnosis. I actually do have a very good handout that if anybody has a patient with TPN this semester and they know about it, I can give it to you ahead of time or after you've had the patient. And it's monitoring a patient with TPN. And laboratory, they usually do baseline studies like CBC, differential, platelets, RBC indices. It's a lot. Lists all the laboratory studies that they do for these patients to keep an eye on them throughout the time that they're on TPN. And actually, they do recommended patient care monitoring. They're going to do vital signs every 8 hours. They're going to keep very, very strict intake and output, daily weights, and they're going to do blood sugars every 6 hours until the patient's blood glucose is stable, and then at least every day. They really watch it very carefully. So it's a protocol that I have on monitoring patients with TPN. If you would like to have any of that information, let me know. Okay, so there's your nursing diagnosis of less than body requirements. I talked just a little bit about total parenteral nutrition. I've also seen it called total nutrient admixture, TNA. It's provided when the GI tract is non-functional. It is administered intravenously, usually through a central venous catheter into the superior vena cava, because you do not want to. We used to, years ago, they try to give some of this total parenteral nutrition IV into just a regular IV, and oh God, when they infiltrated, it was just awful. The poor patients had sloughing, and really the skin, the tissue would break down and necrose. It was just awful, and it was very painful. So you don't want to do that. And it's so much easier now to put in central lines. So if the GI tract is non-functional and can't absorb this, then you have to give the patient the nutrition that they need that we listed before that isn't in regular IV fluids. So it's administered. Solutions include sugar, fat, proteins, electrolytes, vitamins, and trace elements. And all the things that you need to be able to survive. It provides all the calories needed. And in fact, the fat is usually a white lipids solution that is administered as well. It's hypertonic, and therefore it's injected only into high flow central veins to be diluted by the patient's blood right away. Okay. This is just an example of a IV setup you're going to see in lab, where you have a primary line and then you have a piggyback line that goes into it. Secondary port, it's attached into that port, so that you're able to give meds, and you can disconnect that bag and throw that away when that one's done, and then you can add the next medication when it's due. So these are just some pictures that to help you understand what you're going to see in lab tomorrow. This is a secondary intravenous line. It's a tandem intravenous alignment and a intravenous piggyback that's on here. So there's just different ways of doing it, and you'll be seeing one example on Thursday. All right. Now, if you're giving someone IV therapy and you have to maintain it, what are the factors you're going to be keeping an eye on? You're going to watch the flow. So what's going to affect the flow? The flow is related directly to the height of the liquid column. It's related directly to the diameter of the tube's lumen. So if you've got a wider lumen, it's going to go in faster. If you've got a narrow lumen, it's going to go in slower. Go back up to the flow related to the height of the liquid. If you got the bag up high, it's going to go in faster. If you lower it down close to the patient, it's going to go in slower. And if you lower it lower, it's going to stop going in, and then it's going to actually back up if it's you put it too low. So that's why they're always holding the bag over the patient when you see them in the movies. Flow inversely related to the length of the tube. So the length of the tube, if it's longer, it's going to take a longer. If the tube is long, it's going to slow down the flow. And the flow is inversely related to the thickness or viscosity of the fluid. If you've got thicker fluids such as blood or TPN, those things are thicker fluid, they're going to go in slower. Okay? Monitoring IV flow rate, we're going to talk to you about a couple of different ways to calculate the IV flow rate, because we want you to know how to look at the drip factor that is written on the bag where the drip chamber comes from. When you're going to actually spike and prime a bag, and you're going to spike a bag and prime the line, the IV line, and regulate the drip factor with the roller clamp. And when you do that, you're going to have to look on the packaging that the bag came in to determine what is the drip factor for that particular IV set. And you are going to that will help you to determine how many drops per minute, or how many drops are in an ml for that particular IV drip chamber, and you will be able to regulate it by how many drops per minute you do. So we'll teach you that in lab. You'll monitor the flow rate and the amount infused hourly. You're going to look at the drops per ml of infusion sets, so 60 minutes and 1 hour total times the total volume. So there's a couple of different ways to look at this. This is one calculation, but I also threw in a DA one so that you could see what this one is. Using a pediatric drip, micro drip chamber, calculate the IV drip to administer 100 mLs via IV over 30 minutes. So your drip factor is actually 60. So you'll be able, your drips per minute is equal to 100 mLs times 60 drops per 30 minutes. It's equal to, it has to be 200 drops a minute in order to have that. So this is just your DA as well. So hang on one second, I gotta turn the page. This is a pump with a syringe into it, that or a mini infuser for administration of IV medications. That's one type of administration. They actually do deliver meds on it's not this direction, it's horizontal. Actually, the syringe would be horizontal. In pediatrics, we do have at Falmouth Hospital, and probably at Cape Cod Hospital, but definitely Falmouth, a syringe that delivers their antibiotics very often to the patient. Just so you're aware of that, you might see that. Okay. Safety features on these volumetric pumps. They have sensors that detect air in the tubing. They have sensors that detect back pressure if they're occluded or clamped. Say you walked away and you forgot to undo the roller clamp after you started the infusion, or if the IV is infiltrated and has backup. So it actually will tell you if it's a distal or a proximal occlusion, which is kind of cool with these smart pumps. Using an IV pump does not discount the need for that nurse to check that IV and the site of insertion frequently. Pump tubing is automatically clamped now when removed from the pump. That's way cool. It didn't used to happen. It used to happen if you pulled the tubing out of a pump, it would run free, and so you had to make sure you roller clamped it quickly. And some patients got some dangerous, if they had dangerous medications such as magnesium or whatever going through that were added to the IV bag, that could be very, very dangerous. I'm sure Gail will talk about that, but it was not always true that it used to clamp off. Now the tubing, they have special attachments, the safety attachments on the tubing that clamps the tubing the minute it's pulled off a pump. Okay, this is just some examples of equipment that you're going to see. This is a needleless system. We're trying to get away from having needles, and this one it's like a plastic. In the blue section, there's a plastic pointed male adapter that will actually go into where the orangey cap is on the IV, into like the female adapter. Is other needleless access devices that we're trying to get to so that we decrease the risk of needle sticks in staff to protect you. Has more, is administering IV medications using IV push. So you've got some needleless systems in here, but you've also got some that they use needles. So you will see both, but hopefully you will be using needleless systems more often than not as we move ahead. Okay. So this is flushing a vascular device. you're looking to ensure patency of the IV, prevent mixing of incompatible medications or solutions, and normal saline is the best thing to use for flushing. So what you're going to do is, if you're going to give a medication or you're going to start an infusion of a medication, you should actually give an IV flush of normal saline so that there's so much of the tubing is going to be protecting the med coming from the solution that was running in. So you put like a buffer zone in there. And then after the medication is completed being given, you then are going to flush again to flush the rest of that medication through so that when there's no risk of incompatibility with the IV solution that's hanging. And all this will become more clear to you when you're in IV lab and with your instructor over the semester. You're also, when you, the first line in the slide says, you're going to check that the IV is nice and patent before you're actually going to give that IV med. You want to test the IV and make sure it's still good. Discontinuation of an infusion to remove the IV catheter, use aseptic technique and prevent bleeding by applying a dry sterile dressing and put firm pressure on it after you've removed it so that it doesn't bleed. And examine the catheter tip and compare it to a new one. As I said before, you want to take that catheter tip out, make sure no piece of it has been cut off and has escaped into the patient's body or into their heart. You want to make sure that you have it. So as I said, the dangers would be bleeding when you remove a catheter and a catheter embolism, where a plastic tip can be severed and a piece of it travel up to the right ventricle and block the blood flow. So you want to absolutely take care to check that. You want to make sure that no scissors ever go near a catheter, because if the scissors ever cut it and the tip got cut loose, that would be very dangerous. If a catheter has been severed, occlude the vein above the site immediately and apply a tourniquet to prevent the catheter from entering the central circulation. And it's going to have to be surgical removal of the catheter tip at that point. So that's something to just be aware of. Complications of IV therapy. We're going to talk about each one of these individually, but I'm just going to give you the list right now. You've got fluid overload, you've got an air embolism, septicemia and other infections, infiltration and extravasation, phlebitis, thrombophlebitis, hematoma, clotting, and obstruction. Hang on one second. So fluid overload is excessive IV fluid, can lead to heart failure and pulmonary edema. Signs and symptoms would be increased blood pressure, increased CVP, moist crackles cerebral in the lungs, edema, weight gain, dyspnea, shallow but rapid respirations. It can be avoided by using an infusion pump and monitor those infusions very, very carefully. Fluid overload treatment would be to decrease the IV rate, monitor vital signs frequently, assess breathing and lung sounds, place the patient in high Fowlers, contact the physician immediately. And in any of these situations, if you need to, you're going to administer oxygen. If their color is poor, their pulse ox is not adequate, and you're going to be checking that carefully. So monitoring their vital signs frequently, including a pulse ox, and listening to their heart and lung sounds is really key. Air embolus. It's rare, but it's possible. It's usually only with central venous lines. Air embolus can lead to shock and death. The signs and symptoms of this would be dyspnea, cyanosis, decreased blood pressure, weak rapid pulse, chest, shoulder, and lower back pain, and loss of consciousness. Can be avoided. Using the Lurlock system has been great. When you used to have IVs that fell apart before, they'd come apart, and now they lock in place, so that's wonderful. Tubing is completely filled and primed before delivery, and air detector alarms and pumps help to let you know if there's even a minuscule amount of air in those lines, so that's great. Okay. Another complication of IV therapy would be an air embolism. and air embolism is the air embolism. We just talked about that. Sorry. The treatment for it is immediately clamp the cannula, replace a leaking or open infusion system, place patient on their left side in Trendelenburg, assess vital signs and breath sounds, administer O2, and call the physician immediately. That's your treatment. Now we're going to move on to phlebitis. And phlebitis would be erythema or redness, and also a warm area at this insertion site. Phlebitis is an inflammation of the vein, and it can be chemical or it can be mechanical. Chemical would be if the solution or the medication has a high pH or a high osmolality. Mechanical would be it's too large a gauge for the vein, and the IV was in too long or not anchored properly. And bacterial would be poor aseptic technique, so you've given the patient an infection. So your signs and symptoms are going to be that redness or erythema, warm, you feel it be warm to touch at the insertion site, possible pain, tenderness. It's going to have induration, which would be hardness, swelling, and the incidence increases with the increased length of time the IV is left in at the same site, or if you have increased pH or toxicity of the IV solution that's being given. And we did talk about the different chemical, mechanical, and bacterial. Okay. There's the Intravenous Nurses Society. Remember I talked about that they were established in, I think, in the 1970s, and in 75 they started to publish the Journal of Intravenous Nursing. Well, they established criteria for certain complications in IV therapy. And your phlebitis scale, this is your phlebitis scale, so 0 would be no symptoms, 1, 2, 3, and 4, with the different increasing severity of the phlebitis. So treatment, again, would be to DC, report, document, and apply moist heat. So now we've got infiltration. It's cool to touch. That's when it's cool. So your infection, your phlebitis, is going to be redness, pain, and warmth. Your infiltration is going to be cool to touch. It's going to be puffy and edematous, but not necessarily red. It might even be a whitish because you've actually, the fluid going into it is restricted circulation coming in, so it's almost white, and the patient possibly could have pain. Sometimes they don't, though, so, but possibly pain or at least discomfort. And you'll notice a decrease in the flow rate is noted. You notice the IV, probably the pump keeps alarming and saying there's an occlusion and issues with that. It would be basically infiltration is the unintentional administration of IV fluid or med to the surrounding tissue. Make sure that I don't have that in there. I'm sorry, I got that. I'm supposed to have that off of the page. Okay. So the IV fluid or med is in the surrounding tissue now, and it occurs when the IV cannula dislodges or perforates the vein wall, and the fluid then goes into that tissue. It's best if prevented or caught early by inspecting the site hourly for redness, pain, edema, coolness of the site, and leaking of the IV fluid at the site. The INS infiltration scale is listed here. 0 is no symptoms, 1 would be skin is blanched, it's less than 1 area, cool to touch, with or without pain, and 2 would be skin is blanched, edema 1 to 6 inches, so it's a large infiltrate, cool to touch. And this is also continued to the next slide. 3 would be skin is blanched, translucent, gross edema greater than 6 inches, cool to touch, pain, numbness, possible even. And 4 would be skin blanched, translucent, and he continues. Moderate to severe pain, infiltration of any blood or blood product or irritant. And vesicant is blistering, causing or forming blisters because the IV fluid or med seep into the tissue, and that's what happens. The treatment for this would be discontinue it, report it, document, apply moist heat, and may give anti-inflammatory meds when they're ordered. Okay, this is an infiltration. This example of infiltration. This is one arm is normal, the arm on the left is normal, the arm on the right, you can see that it's more swollen than the arm on the left. This is a patient holding their arms. If you try to do this yourself, it's not two different arms. It's it is two different arms, but it's not two different patients. It's the same patient just holding their arms side by side. Here's another example of infiltration. You can see that shiny hand on the bottom there, and it's puffy, obviously. Unfortunately, the next slide shows extravasation, which means that this is an infiltrate of vancomycin into the subcutaneous tissue, causing blistering of the skin, and it's just sometimes the tissue actually gets necrotic and sloughs, and people have even had to have from total parenteral nutrition infiltrates, they've actually had to have skin grafts to fix those. So this is when the irritating IV solution or medication seeps into the tissues, causes pain, burning, and redness at the site, and the treatment varies depending on the solution. Blistering, inflammation, and necrosis of the tissue can occur. For treatment for infiltration varies. You definitely would be obviously restart the infusion proximal of the infiltrated area. Treatment warm versus cold varies with the solution pH, so you're going to have to check on that, and the length of time, time of the infiltration. So you want to check on that before treatment will be ordered. Okay, here's more complications. Another complication, as we talked about before, is infection. And you could have localized redness, swelling, drainage, warmth, and pain. Or you could have systemic septicemia. The patient, it's abrupt temperature elevation. Your patient will be fine and acting fine, and then they'll start a new IV solution, and then bam, they've got an abrupt temperature elevation shortly after the infusion started. They're going to have a backache and headache, elevated pulse and respiratory rate, nausea, vomiting, diarrhea, chills, malaise, vascular collapse, and septic shock if it's severe and it keeps going. The causes could be if you gave them a contaminated IV product. There was a break in aseptic technique, especially if the patient's immunocompromised. Your treatment would be obviously getting blood cultures. You culture the tubing and the solution and the cannula, and you establish a new IV site. But you save that tubing in sterile container so that they can culture it if needed. Okay, so this is thrombophlebitis. This would be the presence of a clot and inflammation in the vein, localized pain, redness, and swelling, warmth at the site or up the vein. The treatment would be to discontinue the IV, apply cold compresses, and then you're going to elevate that extremity and restart in the opposite arm. Okay, hang on 1 second. Hematoma, that would be when blood leaks into the tissues and you have that bulge that looks like a bump because the blood has gone into the area, and then it's going to obviously become a black and blue or ecchymotic area afterwards. Treatment would be to remove the IV, apply pressure in a sterile dressing to elevate the area and to assess the circulation, sensation, and motion of that area to make sure that it's still intact, and notify physician if there's any change or any problem with that. Complication of the clotting and obstruction. Clotting, if you've got a kinked tubing or failure to flush properly after meds. Treatment would be to restart the line. The key thing is do not try to flush the line. If you go to flush that line to see if it's patent and that line it's not flushing, don't keep pushing harder because you're going to flush a clot right into your patient. So you don't want to do that. So if you're having trouble flushing the line and it's not the fluid's not flowing easily when you push on the barrel of that tubing, that syringe, then you want to stop, back off, and you say, I need to get a new IV. The only time that changes is if it's a PICC line or a central line. You get certain nurses are allowed to use the clot buster. They're allowed to use a solution that actually breaks the clot up, so it doesn't send the clot into the patient. It actually breaks the clot, dissolves the clot up, and it's similar medication that's used when patients have strokes, and certain nurses that have been that are able to do that. So they will usually try that if it's a central line, because you don't want to lose that central line. Okay, and this is okay. Putting it in writing, the importance of documentation. So your initial documentation, you want to put the when you put in an IV, you have to be careful to put in exact cannula size and type that you put in, the length of time that it's in place. You got to keep track of, so you want those accurate dates on those IVs, the dressing, and the IV, because it's not supposed to stay in for so certain amount of time, very specific, and particular facilities have their so many hours. So follow your policies and procedures for your place of employment. Let's see, fluid or medication, if it's been administered, client complaints, appearance of the site, MD notification, interventions, client response, and follow-up assessment would be regular and continued assessment and documentation. Okay. Now, that's it for adult IV therapy, but I do want to spend a little bit of time on pediatric considerations of parenteral administration of medications and IV fluids. So, when you give meds to patients, particularly children, you're going to give them oral, otic, ophthalmic, intramuscular, subcutaneous, intradermal, intravenous, and rectal medications. Devices that you might use would be peripheral lock or heparin lock, saline lock. Those are the different types of devices you'd use. Central venous access devices. You could have short-term non-tunneled catheters or long-term tunneled catheters, or even implanted infusion ports. You also might see these implanted infusion ports and central lines in your adults. Peripherally inserted central catheters, or PICCs, those are your PICC lines. We had a baby one time at Falmouth Hospital. The baby had to go up actually to Jordan Hospital, went up to, or South Shore Hospital or Jordan Hospital, I believe Jordan, and had their had a PICC line put in up there. The baby had a size 1 PICC line put in. So you'll be able to appreciate that when you see what size the adults are that you're taking care of later. This is a very important safety device in pediatrics. People are not worrying about it quite as much as they used to, because now you have pretty much everybody's always on a pump. The baby would be on a pump, and the pump would be regulating carefully how much fluid the baby gets. Because you can, if you think about it, you could, if you really think about it for just a second, you realize how quickly and easily you could fluid overload and give more than a baby's supposed to get in an hour of fluid. And if you give like 3 or 4 hours worth of fluid by accident in 10 minutes, that's not a good idea. So this was this is called a pediatric burette, and it has a drip chamber down the bottom. You see that like needle-like thing. Tiny drops go into that drip chamber, and you actually can spike the bag with the chamber, and you put a little bit of fluid into the chamber and hang the chamber up and lock it between the bag and the chamber, so that the baby can only get a maximum of, by accident, it can only get a maximum of like an hour's worth of fluid or something, because you usually have an hour to 2 hours worth of fluid in the burette at a given time. So you'll get to touch this equipment when you all have orientation in pediatric, orientation to pediatric clinical, and that will be this next Tuesday if you are in pediatrics during the first 2 quarters, and if you're in pediatrics in the 3rd or the 4th quarter, then it won't be until March 13th that you have that orientation, but you'll get to touch and see these pieces of equipment. Okay. One of the things you want to think about pediatric patients is if they're 20 pounds or less, you never want a 1,000 ml bag to be hanging above that patient. The maximum volume of IV fluid bag you would hang over that patient would be a 500 ml bag. And you would use that micro drip chamber that I just showed you. That is the micro drip chamber. Anyway, so in my lecture I would have asked you why, but I think I've already explained it, that you would decrease the risk of potentially fluid overloading the patient. Okay. These are patients. This is a tunneled catheter on the left side, and then this is a bent needle that actually goes into an access device, a port if the child is going to receive chemotherapy, or they're giving medications, IV medications that are very caustic and could damage them and need to go into a large vein, then they would be going in through central catheters or that central access device. And this also decreases the amount of times that a child has to be stuck, because they're just going to go into that access device. And they do put MLA on those, on the where the needle goes in through the skin on the right. They put MLA on there before they access it ahead of time to decrease the pain to the children. Okay, this is an example of the implantable venous access device. And this is that self-sealing septum, and that when it points up toward the skin, and the skin goes over it, and you access through that meshed area, and it goes right in. The needle goes right into that meshed area and gives your medication, or actually you can draw blood through them as well. This is an implantable venous access device and a Huber needle with extension tubing. So you might see those. That's the needle that would go into the access device to either draw blood or give medication. Okay. Another thing I wanted to talk about, and actually I don't have a slide on it, is I just want to mention intraosseous needles. And if you can't get an IV in, if someone comes in like to the emergency ward, emergency room, and they are obviously in shock and they need to be fluid resuscitated, you can't get an IV in, and you've got to be able to give them their emergency medications to resuscitate them as well. They may even put in an intraosseous needle, and that would be in the leg. And we can show you those needles when you're doing the code carts in pediatrics with Gail and me. We'll show you what an intraosseous needle looks like, and talk about how it just goes right into the tibia, right into the bone. And when it goes into that bone marrow, you can actually deliver fluids just as if you were in a vein. Okay. So let me just get to my next slide to catch up. Okay, so measurement of intake and output is going to be very, very strict when you have a patient that has IV therapy, and particularly if you have a baby, a pediatric patient. The patient is incontinent of urine still, and they're just a baby. You would be weighing the diaper, and actually 1 ml of urine is equal to a gram. So you subtract the weight of the dry diaper from the wet diaper, and that gives you the number of grams, or your urine output, your mLs of urine. Because it gives you the grams, so then you can determine how many mLs the baby has put out in urine over a given time, and they usually keep an eye on it hourly. Parenteral fluid therapy, you're going to have site selection. You can use scalp veins as IVs in children. Extremities, they'll use the upper and the lower extremities, so you will use the legs and the hands and the arms. Intraosseous infusion, as I said, and a surgical cut down if they need to. The intraosseous needle infusions are usually 6 years old and younger. Let's see. In pediatric patients, usually the IV, they'll use a 22 to 24 gauge catheter if therapy is expected to be less than 5 days. It's best to use the smallest gauge and the shortest amount of time to prevent complications. So you want to have a small gauge needle, and you want to leave it in as shortest amount of time as you possibly can in order to prevent complications. Let's see. The intraosseous needle is a very rapid, safe, often life-saving alternative route. It is a large bore needle. It's a Cook's intraosseous needle is inserted into the proximal tibia. It's practiced in PALS, actually. You feel the pop when you push the needle. It goes through the bone, pops into the bone marrow. It is very painful, so usually the child is unconscious when they've attempted to do this. If they're semi-conscious, they would actually use anesthesia. Here are some pictures of different access, venous access to children for IV therapy. Preferred sites for venous access in infants. They do use the feet, as I said. You avoid the scalp if it's possible, more because if you use a scalp vein, you have to shave the head, and it usually upsets the parents to see the IV in the baby's head. the kind of cool thing is the head scalp doesn't move, or the head is not flexible like an arm, so you often can keep an IV intact and in place for a little bit longer than you could in a hand. Hand sometimes lasts for 10 minutes. Equipment for fluid therapy would be your catheters, your needleless systems, your decrease your needle injuries, and your infusion pumps. And here's some examples of your needleless systems to be able to access a medication and to deliver it through an IV. Here's protection over the hand so that the child doesn't bump it or knock the IV out, and also protects them from hopefully picking at it as well. So pulling it out themselves. The peripheral intravenous lines, you have to secure them. You have to, removal of them carefully. Complications, again, would be your infiltration and your extravasation if you have an infiltrate of a toxic substance. Infiltration in children is harder to detect, particularly in infants, due to their increased subcutaneous fat and often lots of tape used to secure the IV. You want to avoid the IV bracelet limb if you possibly can, because that can act as a tourniquet, and you want to be very, very careful that I don't know where my light. Okay, you want to be very careful not to have if it gets infiltrated at all, the ID bracelet can restrict the flow of fluid. Check for blood return, although it doesn't always work. It often doesn't work well with children. Flushing with observation is really the best way to determine if a patient's IV line, especially in an infant or child, is intact. Parenteral feedings, you provide nutrition through the IV route. It's total parenteral nutrition, as I said before, hyperalimentation, lipid infusion. And usually this is done through a central line. They don't put those through peripheral lines. Okay, we've got a couple of questions for you to take a look at. This is an elderly nursing home resident has refused to eat or drink for several days and is admitted to the hospital. The nurse should assess which of the following: your increased blood pressure, a weak rapid pulse, moist mucous membranes, jugular vein distension, and which one is correct is number 2. A client that has not eaten or had anything to drink for several days would be experiencing fluid volume deficit. So you're going to take a look at the weak rapid pulse. Okay. A man brings his elderly wife into the emergency department. He states that she's been vomiting and has had diarrhea for 2 days. She appears lethargic and complaining of leg cramps. What should the nurse do first? Start an IV, review the results of serum electrolytes, offer the woman foods that are high in sodium and potassium. Let's see, she's been vomiting and has diarrhea for 2 days. You think she wants to eat things and have high in sodium food? Administer an antiemetic. So you're going to further assess the labs to see what action to determine the appropriate, whether she does need IV fluids or whether she in fact does need a particular type of IV fluid. So you want to always get that information so that you can help the patient. So that is the end of my lecture, and I appreciate your having to watch this and listen to this through Moodle as we move forward. I didn't want you to miss the content and just have to review the lecture. So I am doing this tonight during the snowstorm, and I'm going to load this up to Moodle with the link and send you all a notification about this. So you take care of yourselves, be safe, and we'll see you hopefully Thursday morning for the IV therapy lab. And read through your procedures so that you'll be able to do them. But your instructor will talk you through them. You're going to be, each one of you will be with your first clinical instructor that you have for the first quarter or first half of the semester if you are in med-surg the first half. You all take care.